Let's go ahead and fast forward a few hours. We are now at the bedside. Nurse gave us a call and said that Ms. G has steadily dropped her pressure. She's now, quote unquote, maxed on norepinephrine at 30 micrograms per minute, and she's on that vasopressin at 0.04 units per minute. She's received her hydrocortisone, her fludrocortisone, but despite all of this, she's again hypotensive, and she's now unfortunately less responsive, and her urine output has completely dropped off. So she seems to be getting a bit sicker.
The fact that our patient has gone from 15 to 30 of norepi with the addition of vasopressin and steroids is very worrisome. And this is a situation where we got to take this seriously. We got to go to the bedside and we got to think about a bunch of things. So to kind of walk through kind of an outline of the things I think about in a situation like this. Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your co-host, Dr. Nick Mark.
And I'm Dr. Cyrus Askin. Nick, how do you feel about pickleball?
Pickleball. Well, it was invented here in Washington State, by the way. Actually by somebody who I work with's like in-laws. So I feel this deep Washington State connection to pickleball. Not that I'm any good at it.
Oh, well, I ask because I'm sort of on this sabbatical, if you will. I'm living abroad for a little while, and my clinical work isn't all that busy, but I'm telling you, I probably log anywhere from 10 to 14 hours of pickleball a week, and I'd like to think I've gotten reasonably good at it so that I am fully prepared for my days at the retirement community sometime in the next 40 or 50 years.
Dude, in my neighborhood, we have like our neighborhood Olympics where each like household competes, and one of the events is pickleball. So maybe next year when you're back in the States, you can come be a ringer for us.
Yeah, I'll have to discuss with my partner. She has, unfortunately for me, gotten vastly superior to me, it would seem, and so I'm sort of beholden to her if we're going to have any hope of actually functionally working as ringers. But I definitely think there's a possibility.
All right, we'll put a pin in that. I have a little anecdote to share. So last week I was dropping my kid off at nature summer camp, and just as we're like pulling into the trailhead, the check engine light goes on. So, I drop him off at summer camp, and then because I'm me, I have the little diagnostic thing. So I plug that into the car and I see the error code. I write it down, I Google it so I know like what the exact error code is. And then I go to my mechanic and I tell him, hey, I diagnosed the car. It's got, a coolant thermostat problem. And I kind of watch his face as he sort of imperceptibly kind of takes a breath in, holds it for just a second, breathes out very slightly, and then very calmly and slowly explains to me why that is true, but there's more to it. That even though that sensor is the one that's reporting a problem, usually the problem is an oil leak somewhere else in the engine. And so if I'd like, he can replace that $2,000 part, or he can just, kind of look around and find what the real problem is. Anyway, so he finds the real problem. It costs $100 to replace the little gasket that was broken instead of $2,000 that I wanted him to spend. And I realized that I am that patient. I was that person who Googled it and was like, I know what the problem is. Fix this thing. So anyway, humbling reminder that it's really good to be mindful of Dr. Google, to remember that your expertise doesn't cross into other domains. Being a doctor doesn't make you any good at diagnosing cars.
Right.
Yeah. And also get a good, honest mechanic.
I think that's great. I thought that this story was going to go a little different, and you were going to pull out your iStat and check your car's lactate. But alas, you did not.
No. You get a diagnostic code. It's actually very much like clinical medicine. There's even a great JAMA article from a while ago where somebody points out that the Car Talk guys basically have all the attributes of being great diagnosticians. Like the way they listen to an engine is very clinical.
Oh yeah, click and clack.
Thoughtful.
Yeah, no, I remember them fondly from my childhood. But anyway, I know that our audience didn't come here to listen to us banter. On that note, we should probably bring things back to our topic of the day, which is vasopressors part 2.
Yes. Welcome back for part 2 in our series on vasopressors. We're hoping that, like Terminator 2, Godfather 2, Ghostbusters 2, Aliens, and Empire Strikes Back, this can be the rare sequel that's even better than the original. Just to remind you, in part 1 of this episode, we talked about what vasopressors are, how they work, and how to titrate them. Here in part 2, we're going to talk about some more advanced situations, including how and when you might want to combine multiple pressors, what we can do when vasopressors fail us, specifically adding corticosteroids or vasodilator scavengers. And then finally, we'll talk about something really important, which is how we can help people wean from vasopressors as part of their recovery from critical illness.
Throughout this 2-part episode, we're going to stay focused on how we use vasopressors to care for people with critical illness. By following the journey of the patient from our last episode, from the ED to the ICU to the wards and then home.
Buckle up. This is going to be a fun one, people. So before we get started, just a quick aside. In part 2, we are going to build on some of the physiology that we discussed back in part 1. If you haven't listened to part 1, that's totally fine. Just know that a lot of the things that we're going to take for granted today, concepts like SVR, catecholamine versus non-catecholamine, adrenergic receptors, we talk about those a lot more in part 1. So if you haven't listened to part 1 yet, consider going back. You don't have to. Anyway, without further ado, we bring you part 2. Cyrus, do you mind getting us up to speed on the case?
Absolutely. So in part 1, we introduced Miss Gonzalez, who's a 65-year-old lady who came in with a history of hypertension, rheumatoid arthritis, and presented to the ED with fever and dysuria. But unfortunately, she subsequently developed a little bit of septic shock, if you will. She was started on norepinephrine via peripheral IV, and her BP improved. However, she later required intubation for respiratory failure, maybe because of some overexuberant volume resuscitation. Her blood pressure fell with that intubation, which is common in people with sepsis physiology, but we were able to stabilize her with push-dose pressors. We discussed when to place a central line and decided that even though peripheral access is okay for moderate dose vasopressors, it probably makes sense to place a central line in someone who's septic and in respiratory failure. So let's go ahead and pick back up on this case as Miss Gonzalez transitions from the ED to the ICU. So here she is now in the ICU, and unfortunately, her blood pressure is low again. She is hypotensive at 88/40 with a MAP of 56, and her heart rate is 92. This is on 15 micrograms per minute of norepinephrine. She's also febrile to 39 degrees centigrade, and she's breathing 24 times a minute on moderate ventilator support. She's awake, she's opening her eyes, and able to nod questions and follow commands with a RAS of 0 to -1. Her urine output is minimal, just about 10 cc's in the last hour, and her cap refill is delayed. So, Nick, how would you approach Miss Gonzalez now?
Well, it seems like a textbook example of somebody who's having worsening septic shock. We'll talk about kind of our differential for what to think about, but while we're thinking about what could be causing her to get worse, now is probably the time to add a second vasopressor. Another thing that we should do right away is we should consider checking for volume responsiveness. We know she probably wasn't volume responsive before and she got a lot of volume, but things may have changed. So it's worth considering that as well. We're going to dedicate a whole future episode to the topic of assessing volume tolerance and volume responsiveness. So I'll just leave it at that for now.
Okay, so Nick, what vasopressor would you want to add next?
Vasopressin.
Okay, so you're going to add vasopressin, but why would you even consider adding a second one? Why not just keep going higher and higher on the first one? And then, we talked about vasopressin as being unsafe peripherally. I mean, is it a medication we should be weary of using?
Great questions. Yes. So in part 1, we talked about how you probably shouldn't give vasopressin through a peripheral IV. You should probably save it for central access because there's nothing you can do if it extravasates. But I think there's a couple really compelling reasons why we should add vasopressin in this patient who does have central access. First, biochemically, we know that people with septic shock have a relative deficiency of endogenous vasopressin. So there's a theoretical reason that vasopressin may be helpful there. I don't put too much stock in that personally, but I think it is a reason. Another reason, pharmacologically, is that there's evidence that there's synergy between vasopressors that act via different receptors. So in this case, she's on norepinephrine, which is acting on alpha adrenergic receptors, and adding vasopressin, which is acting on the V1 receptors, may actually get us more effect than just going up on one. Finally, and I think what's probably the most compelling evidence is clinically. There's evidence from at least one RCT that a subset of patients on norepi may benefit from addition of adding vasopressin, but only if you add vasopressin when the norepi is at a low to medium dose. So the benefit seems to go away if you wait too long.
That seems to be a really important point of discussion, Nick. Do you think we could discuss that RCT a bit further?
Yeah, so this evidence comes from the VAST trial, VASTT, great name for a study. ICU patients with septic shock who were receiving norepi at least 5 mics per minute were randomized to either starting vasopressin or to get a higher dose of norepi. Now, overall, the 28-day mortality was not significantly lower with vasopressin. It was 35 versus 39%. But among the pre-specified subgroup of people with less severe shock, people who were under 15 of norepi, mortality was about 10% lower, both at 30 days and at 90 days, which was quite significant. So this really, you might kind of poo-poo this and say, oh, that's a post-hoc subgroup, blah, 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 blah. But this is a big effect size. This is a number needed to treat of 10. And it suggests that if we add vasopressin when norepi is still in that mid-dose range, it may be significantly beneficial. And I think it's too good to not do it, even if it's kind of statistically meh.
Yeah. So, I think that's great. And to put this another way, we often say, Nick, that medicine isn't a cookbook, and it's really important that we individualize treatment to meet the specific needs of our patients. So, for example, not everyone with sepsis who's on norepinephrine needs to be on vasopressin too. But if we are following the cookbook, and sometimes it's appropriate to do so, I'd say we probably should stick close to the recipe that we know works. And so if we have good data to support the use of adding vasopressin when your norepinephrine dose is kind of in that moderate range, I think that's a perfectly fine way to proceed.
Absolutely. Very well said. I think that's actually a great segue to our discussion of when to add corticosteroids. We should probably back up for a second and kind of answer the obvious question of why do you add corticosteroids in sepsis? The answer is that corticosteroids do a couple of things that are helpful. One is they increase transcription of the adrenergic receptors. So if you give steroids, you're actually making the vascular smooth muscle more responsive to the effects of vasopressors. That means there's going to be synergy between pressors and steroids. In most people with vasodilatory shock who require more than one pressor, that's usually when I add corticosteroids. I guess some other context that we should talk about is corticosteroids are like this pendulum in critical care that kind of swings into and out of widespread use. And that pendulum is currently swinging towards widespread use, I would say. Recently, we've seen a couple of really important trials that have showed improved survival with corticosteroids in people with septic shock. And there have also been some studies of steroids in other diseases. So, for example, there's a survival benefit to adding steroids to people with severe community-acquired pneumonia. And of course, in people who are hospitalized with COVID pneumonia who are hypoxic, there's a big survival benefit to adding corticosteroids there as well. So there's a lot of reasons to like steroids in critical illness, and these are just a few of them.
Absolutely, yeah. And I think the study that you're alluding to or at least one of the recent studies for hydrocortisone in community-acquired pneumonia was the Cape Cod trial.
Right. So Cape Cod and Recovery are two trials not to miss. Those are very, very important in kind of understanding the widening role of corticosteroids in recent years.
Absolutely. So Nick, now that we've talked about that a little bit, I know that you have some particular thoughts about what steroids to use and how to use them. And notice that I use the term steroids in plural. Can you clear that up for us?
Yes, I did indeed notice that. Nice setup. So I think in order to understand this, we should present a couple more trials and talk about how they sort of color our thinking. So there were 2 large multi-center RCTs, the 2002 Anon trial and the 2018 Approaches trial. Both of these trials found a significant decrease in mortality when patients with septic shock were randomized to receive hydrocortisone and fludrocortisone. They also found more vasopressor-free days. They were faster to wean from mechanical ventilation, and they were less likely to have organ failure. So these 2 trials provide very compelling evidence for a survival benefit with hydrocortisone and fludrocortisone. On the other hand, another big trial that was done recently in 2018 was the adrenal trial. This trial did not find a mortality benefit, but one crucial difference between these trials was adrenal used hydrocortisone alone. It also did some weird stuff where they infused it continuously instead of doing it the way actual humans give this drug. Another point of evidence that really colors my thinking is there was a large observational study that was done just this year in 2023, where they looked at 88,000 people who had received either hydrocortisone or hydrocortisone and fludrocortisone for sepsis. And they found that the people who had gotten both had significantly lower mortality than those who had only received hydrocortisone.
I think there is, as I recall from, I want to say New England Journal of Medicine 2008 was the Corticus trial that again only focused on hydrocortisone and showed that there is that increase in reversal of shock, but didn't show a survival benefit. So overall, there seems to be good data for the two drugs, hydrocortisone and fludrocortisone, in unison, and some data for hydrocortisone, monotherapy, whether it's a mortality benefit or hastening shock reversal. And so when I look at all of that data, I tend to agree with you, Nick. And really the conclusion I draw is that low dose hydrocortisone plus fludrocortisone certainly appears to reduce mortality in sepsis. And while there may be some benefit with hydrocortisone monotherapy, it might just not be as robust.
Absolutely. As you said before, Cyrus, medicine isn't a cookbook, but if we are going to follow a recipe, we ought to follow it correctly. And in this case, the recipe book tells us that hydrocortisone plus fludrocortisone appears to be the ingredients that give us improved survival in septic shock.
Yeah, and I think it's probably reasonable to caveat that by saying that the surviving sepsis guidelines do recommend hydrocortisone, but not fludrocortisone for people in septic shock. So if you're, if you're a purist or if you get tested on that for whatever reason, it's a reasonable thing to remember.
I think that's a fair point, and it's good to acknowledge that, Cyrus. The way I see it is that the data for using fludrocortisone and hydrocortisone, 2 RCTs and a large observational trial, is strong, but not overwhelming. But on the other hand, fludrocortisone is a cheap generic drug. It's orally bioavailable. It's a tablet. It costs 40 cents a day. Personally, I think the data is pretty compelling and the downsides are minimal. So I use fludrocortisone plus hydrocortisone for people in septic shock.
And Nick, I do the same thing. So that's the practice pattern I've observed amongst my colleagues and mentors. So I'll probably keep doing it. And so on that note, I think that's a great discussion. And let's just summarize. So Ms. G is on that intermediate dose of norepinephrine, but because she wasn't meeting her blood pressure goals, we decided to add both vasopressin and the double whammy of hydrocortisone and fludrocortisone. So with that,
Great.
Let's go ahead and fast forward a few hours. And we'll say that we are now at the bedside. Nurse gave us a call and said that Ms. G has steadily dropped her pressure. She's now, quote unquote, maxed on norepinephrine at 30 micrograms per minute. And she's on that vasopressin at 0.04 units per minute. She's received her hydrocortisone, her fludrocortisone. But despite all of this, she's again hypotensive. And she's now, unfortunately, less responsive, and her urine output has completely dropped off. So she seems to be getting a bit sicker. Nick, what do we do? What is our next step?
So a couple of things. But first, I'm going to push back on the framing slightly because there really is no max dose of norepinephrine. The issue is that there's diminishing returns if we escalate it to higher and higher doses, because usually what happens is the receptors for it get saturated. But the response depressors is somewhat individual, right? So it's okay to go on higher doses if someone's responding to them. I should also point out that you can go higher than 0.03 or 0.04 units per minute of vasopressin too. We don't usually do that because the risk of mesenteric ischemia goes up, but it is a possibility. That said, the fact that our patient has gone from 15 to 30 of norepi with the addition of vasopressin and steroids is very worrisome. And this is a situation where we got to take this seriously. We got to go to the bedside and we got to think about a bunch of things. So to kind of walk through kind of an outline of the things I think about in a situation like this. First off, we have to make sure we're not missing something. In medicine, we love parsimony. We want one disease that explains everything, but we have to remember that in critical illness, Occam's razor doesn't necessarily apply. Instead, we should think about Hickham's dictum. Patients can have as many problems as they damn well please. So let's go back to the bedside. Let's make sure, with the help of our friend, the ultrasound machine, that we haven't missed something. And just to plug our first episode on undifferentiated shock, we'll talk a lot more about how you can do this there for people who want to go back. There's a couple of things in particular that I want to look at, though. One is an undrained source of infection. 2 is concomitant cardiogenic shock. And we should also talk about dynamic LVOT obstruction. We should finally think about things like acidosis and then vasoplegia. Those are also important. And maybe we could throw onto that list anaphylaxis to medications if we're particularly worried that there might be some other cause.
That's a fantastic review of considerations that we should have at the bedside. And so I think to summarize the differential for someone not responding to vasopressors, you want to think about an undrained infection. You want to think about cardiac causes. So a stress cardiomyopathy, for example, a dynamic LVOT obstruction. You might want to consider whether your adrenergic receptors aren't working. So is this person also on a beta blockade? Are they suffering from hypothyroidism or adrenal insufficiency, which hopefully you've mitigated with your steroids, but sometimes it can take a little while. Do they have a severe acidosis? Do they have some degree of anaphylaxis or vasoplegia as well? So having summarized that, Nick, why don't we go through some of those one by one?
Let's do it. So first off, undrained infection. So antibiotics are great, but they don't get into abscesses well. Abscesses larger than about 5 centimeters are not effectively treated by antibiotics. So if somebody's in septic shock and they're getting sicker despite effective antibiotics, I always think, number one, are they really effective antibiotics? Do I need to broaden coverage? But number two, am I missing something? Is there an undrained infection? Should I, do I see something with point of care ultrasound? And should I get a CT scan to look further? That's definitely something we should think about in this patient.
Perfect. And Nick, what about the stress cardiomyopathy that we mentioned?
Yeah, so stress cardiomyopathy is surprisingly common in people with sepsis. There's actually more than one type. So you can have sepsis-induced myocardial dysfunction, which is kind of a global dysfunction infecting the whole LV. This is, kind of not any area or vascular territory, but the whole LV is affected. A large number of people with sepsis, perhaps as many as a quarter, will develop this if they have severe septic shock. And not surprisingly, this is associated with a worse prognosis. On the other hand, there's something called sepsis-induced cardiomyopathy, which we often know as Takotsubo cardiomyopathy. This is a slightly rarer cause of myocardial dysfunction in sepsis that occurs in, maybe low single-digit % of people. And this is, more common in women, and it typically affects the apex of the LV. So you get this sort of characteristic ballooning of the apex. The reason why it's called Takotsubo cardiomyopathy is because in Japan, they apparently use these kind of interesting shaped jars to catch octopuses. And, this is the shape that the LV resembles if you happen to see it. Both types of stress cardiomyopathy are going to be managed pretty similarly. Both of them will have somebody who's got worsening cardiac output, worsening shock, and you'll see clues like a low mixed venous oxygen saturation. On echo, you'll see that the LV is abnormal, either in the apex or globally. And this is a situation where adding some inotrope support can be very beneficial. So either epinephrine or dobutamine can be very helpful to these patients.
Nick, I think that's a great discussion. And it does remind me that in patients like this for whom we're adding vasopressors, sometimes those vasopressors can actually unmask an underlying cardiomyopathy. And specifically, I think of the question that I'd posed to you before is, you give someone push dose phenylephrine who has an underlying, cardiac issue. Let's say they have systolic heart failure. You don't know about it. You give them phenylephrine and then they have cardiac collapse as a function of that. Or in this case, you have someone who's requiring increasing doses of a vasopressor infusion. And unfortunately, that heart that was pumping better against low afterload and initially appeared normal is now failing with the increase in SVR. So both situations where the heart could appear to be functioning okay at first, and then as the patient gets sicker and we have to make adjustments, things aren't looking so hot. And as we've said probably 1,000 times already, that's just another plug for point of care ultrasound.
Yeah, I think that's a great point. And I think, that's sort of the physiology of somebody's heart is doing well against low afterload, but when you normalize the afterload, you kind of unmask heart failure. That's a really important physiology to remember. I kind of think of it as like, if the afterload is set to easy, the heart's doing really well, but once you normalize that and it has some actual afterload to pump against, it's suddenly not able to provide enough oxygen delivery. So very important to keep that front of mind.
Absolutely, Nick. So another topic that I think would be worth discussing would be the dynamic LVOT obstruction. Do you want to delve into that with me?
Yeah, we should We should definitely take a few minutes to talk about that. So I feel like I never really got great teaching on this topic when I was a resident or a fellow. And I got to say, dynamic LV outflow tract obstruction is an absolutely crucial topic to understand if you use vasopressors to take care of sick patients. So in order to kind of break this down, let's step back and talk about some physiology. So let's say that you have a patient with long-standing hypertension and they've got some degree of LV hypertrophy. They come into the hospital and they've got septic shock. Now, because of the hypertrophy, their left ventricle outflow tract, or LVOT, is narrowed somewhat. This creates a pressure gradient from the LV, which is high pressure, to the aorta, which is lower pressure. Now, because a lot of blood is going through a small area, that means the velocity has to be higher. And high velocities can pull on the papillary muscles via the Venturi effect. And this can cause the leaflet of the mitral valve to flop over into the LVOT. This is called systolic anterior motion of the mitral valve, or SAM. And SAM is really bad for two reasons. It further narrows the LV outflow tract, which is already narrow because there's this big floppy mitral valve leaflet in the way. And it opens the mitral valve and causes mitral regurgitation. So it can cause pulmonary edema and other problems because blood is going backwards, not forwards.
I think that's a great discussion. I think it's important to note that the underlying physiology or pathophysiology that sets the stage for a dynamic LVOT obstruction often needs to be unmasked. And so initially, that person who's not experiencing sepsis physiology may be fine. But then all of a sudden, when they have sepsis, or suffering from sepsis, I should say, and the pressure in the aorta gets lower and the gradient increases, we start to see problems. And furthermore, the things that we do to try to help these patients can often contribute to the problem. So, for example, if we add inotropy, such as with norepinephrine, that's going to raise the pressure in the left ventricle. Raising the pressure in the left ventricle is going to increase that gradient across the LVOT, and that's going to cause a dynamic LVOT obstruction. Specifically, we see LVOT obstructions or systolic anterior motion in really two groups of patients. Classically, we'll see it in hypertrophic cardiomyopathy, in patients whose LVOT is extremely narrow at baseline due to septal hypertrophy. However, we can also see dynamic LVOT obstructions in folks without hypertrophic cardiomyopathy when there are changes in loading conditions, such as hypovolemia, hypotension, an increased heart rate, and or contractility. And so this is really most common in older patients with longstanding hypertension, just like our patient.
Great point. Yes, absolutely. And it's worth remembering that we usually talk about dynamic LVOT obstruction in the context of septic shock, but you can actually see this in other types of shock too when there's changes in loading conditions. So for example, if somebody has a lot of blood loss and their LV filling gets compromised and they're pumping really hard to compensate, you can see it there too. So watch out for dynamic LV outflow tract obstruction also in the setting of blood loss or severe hypovolemia.
And from a clinical perspective, Nick, how does a dynamic LVOT obstruction present?
So the classic story here is somebody whose blood pressure gets worse the more pressors they're on. So if you get called about this, if somebody was kind of stable on 5 mics of norepi, and then all of a sudden they've shot up to 30 and, going up seems to make things worse, LV outflow tract obstruction should be on your mind. Also, whenever you hear about vasopressor refractory shock, always consider dynamic LV outflow tract obstruction. There's a couple other hints that we might see when we examine the patient. So you might hear a new systolic murmur. You may see pulmonary edema, or I should say, you should hear pulmonary edema due to the mitral regurg. And another really valuable clue is a narrow pulse pressure, which is not typical in sepsis.
That's exactly right. Typically, the pulse pressure in sepsis, as we mentioned in prior episodes, is wide. Pulse pressure is proportional to your stroke volume, and most people with distributive shock have a wide pulse pressure with a low diastolic blood pressure. So if you see someone all of a sudden go from having the expected wide pulse pressure to a narrow pulse pressure, perhaps with some of these other findings, it should definitely raise your suspicions for a dynamic LVOT obstruction.
Absolutely. So now that we understand what dynamic LV obstruction is, how do we diagnose it?
Yeah, so this is crazy, I know, but the key to making the diagnosis is point of care ultrasound or POCUS, our friend that we use all the time in the intensive care unit. And so the classic finding in a dynamic LVOT obstruction would be high velocity, late peaking, continuous wave Doppler signal across the LVOT. So typically you'll get a good apical 4-chamber view and drop your Doppler right at that LVOT kind of where the aorta is, and you'll see the classic dagger shape on your continuous wave Doppler due to the late peaking spike that is occurring as a function of that gradient that is increased. Typically, the velocity that you're going to see there is about 3 meters per second, which corresponds to a gradient of greater than 30 millimeters of mercury. I know that we will plan to have some images and videos on the website to sort of demonstrate this a bit better. And so we look forward to sharing that with you. But Nick, now that we've made the diagnosis, we've talked a little bit about what you should expect to find. What do we do about it?
So let's think about the problems that caused it, and then we can fix it. So one issue is hypovolemia. If the LV is underfilled, the outflow tract gets smaller. Another is low afterload if they're extremely vasodilated. And then a third is very, very high inotropy. So the heart is squeezing really hard. So to correct shock due to dynamic LV outflow tract obstruction, we basically need to undo all of those things. So we can correct hypovolemia if it's present. We want to stop inotropes. So typically this means changing your pressors around. So if you diagnose this, you want to get off of those pressors with intrinsic inotropic effects like epinephrine and norepinephrine and get onto pressors that raise afterload that are pure vasoconstrictors. So this means vasopressin and phenylephrine are your two best friends. In rare cases, or I should say in some cases, you also need to do some beta blockade to decrease inotropy further. We could dedicate a whole future podcast to this perhaps, but I'll just put a plug for this is a situation where esmolol can be very valuable because it's short acting. So if the person doesn't tolerate it, it's only a short-lived mistake to add it.
I think there's definitely a place for those medications in certain cases, although we often get a little worried about using beta blockers in septic shock. But this may be a circumstance where it would be worthwhile. And because of the nuance here, I do agree with you, Nick, that perhaps another episode on dynamic LVOT obstruction would be a good idea.
I think the key takeaway for our audience is think about this problem when you have somebody who's getting sicker despite more pressors. If somebody's getting more hypotensive despite more pressors, this should cross your mind.
Perfect. So we've talked about LVOT obstruction for a little while now. What about acidosis in our septic patients?
So severe acidosis is going to make your pressors less effective. There's a couple of reasons for this. One is that smooth muscle that surrounds your arterioles and what provides your SVR is not going to work as well in acid conditions. So as you become progressively acidemic, like your pH is less than 7, your vascular smooth muscle is going to get loose and floppy, and your blood pressure is going to plummet. Acidosis can also affect catecholamine vasopressors directly. That's probably not the major reason, though. What I would say is you should always do a VBG in somebody with worsening shock just to make sure they don't have a progressive acidosis. Assuming they do have acidosis, probably, and this is somebody on the ventilator, I should say, maybe our best option is just to increase the minute ventilation. That's probably the best way to get her pH above 7 or ideally above 7.2. Other things we could consider in extreme cases, we could start a bicarbonate infusion, not pushes, and we could also do CRRT if we need to.
We spent some time discussing some of these important findings that we may come across in the ICU. It was a great discussion. So let's work through those in the context of our patients. So we're going to say we're now at the bedside. We're taking a look at Ms. Gonzalez. We're examining her art with ultrasound. And fortunately, you do not see evidence of a stress cardiomyopathy or septic cardiomyopathy. Nor do you see evidence of dynamic LVOT obstruction or systolic anterior motion mitral valve. So you keep looking and you think there could be some perinephric fluid on fast exam. So her heart rate's now 110, her blood pressure's 90/35, her respiratory rate and her vent settings are unchanged. You check a blood gas, her pH is 7.3, and her SCVO2 drawn from the central line is 68%. So what are we going to do next?
Okay, so a lot of useful information there. So first of all, I am relieved that she does not appear to have a cardiac cause of worsening shock, but I'm worried that she may have an undrained collection of infected fluid, which is causing her sepsis to get worse. So I think what we need to do is we need to get her a CT scan to confirm this. If she does indeed have an abscess, that scan will help IR to plan for potential drain placement. In the meantime, though, blood pressure 90/35, we need to add a third pressor and consider adding a vasodilator scavenger as well.
Perfect. Yeah, this is yet another plug for stabilize it first and then proceed with your diagnostic algorithm. So, Nick, what would you do? Would you add a pressor? Would you add a scavenger? If you're adding a pressor, what would you choose?
Okay, so let's talk about both. We'll talk about the pressor first. So I'd probably go with epinephrine in this case. Her heart rate is 110. So, theoretically, epinephrine is a good choice if I want a little bit more inotropy. If I have somebody whose heart rate is much faster, somebody like who's in AFib with RVR, I might lean more on phenylephrine. There's good physiology there, but there actually isn't great evidence. So there have been a couple of trials where they compared norepinephrine and phenylephrine, and they found that the difference in heart rate was only about 4 beats per minute. So phenylephrine doesn't really cause that much of a difference, less of an increase in heart rate. I should also say that based on some clinical trials, phenylephrine and dopamine are probably just not as good pressors. There was a large RCT that randomized people to either norepi or dopamine. Mortality was the same, but there were a lot more arrhythmias with dopamine. So dopamine is almost never my third choice unless the person's like super bradycardic. There was another interesting piece of evidence during the pandemic, which was that there was a shortage of norepinephrine, which kind of provided this natural experiment where some hospitals were using more phenylephrine. And we actually could see from that people admitted to hospitals during periods of norepinephrine shortage were more likely to die. So pretty suggestive that norepi is better than phenylephrine. So I don't use that first line too. In this patient, her heart rate is a little bit elevated, but not a lot. I would probably go norepi first, vaso second, epi third, unless there's a really compelling reason to use something else. That being said, there are other options. So Cyrus, let me ask you, do you use a lot of angiotensin II in your practice?
That's a great question. So I have used it before. I don't really have to consider it. It's not readily available in my current shop, but I've certainly used it before. And in theory, it's definitely got merits. It's just unfortunately a case where the evidence is not that compelling yet. So the best trial of angiotensin II was the Athos 3 trial, which was a placebo-controlled trial. So essentially the trial agent versus normal saline. And it found that the dose of catecholamine vasopressors decreased, but didn't find any change in more patient-centered outcomes. So again, not super compelling. And furthermore, in theory, it would really be most effective in patients for whom a point-of-care renin assay is available, and those just aren't that common in the intensive care units I've practiced in.
Yeah, that's a great point. And I think you hit the nail on the head that like showing that a pressor is better than normal saline placebo is not super compelling evidence. That said, there probably are a subset of people with high renin shock who respond very favorably to angiotensin II. Anecdotally, I've seen people like this before. There was a planned post hoc subgroup analysis of Athos 3 that found decreased mortality in people with high renin shock who received AT2. So even though the trial as a whole did not find a mortality benefit, a pre-planned subgroup did. Unfortunately, I don't know from looking at somebody at the bedside what their renin level is, and I can't get a renin test result fast enough to use it. So it doesn't mean that I never use angiotensin II. I do use it sometimes as a third line pressor, and some people respond very well to it. The problem is it's just really hard to know a priori who those people are, which to me kind of limits my adoption of it.
Yeah, it wouldn't surprise me if angiotensin II was more widely used in 5 years, but I think the jury is just still out. I'd love to see a head-to-head trial between AT2 and perhaps vasopressin to see if there might be a signal for using AT2 as a second-line pressor. But I just don't know that such a trial will ever get funded. So I guess we're just left scratching our heads.
Yeah. I think a large randomized trial of expensive drug vasopressin versus uber expensive drug angiotensin II might not be in the cards anytime soon. We'll see. Anyway, we'll have to circle back on that in a future season as well, because there may be more evidence on that developed in the next year or two.
Absolutely. So, moving on, Nick, you had mentioned those vasodilator scavengers. We talked about those a little bit. Can you explain that concept a little bit more?
Yeah. So I usually, or increasingly, I use vasodilator scavengers in the third line, meaning that when I add the third pressor, I also add vasodilator scavengers. So our typical approach to somebody who's got a profoundly low SVR, vasoplegia, is to add vasoconstrictors. But in some cases, this isn't enough, and we need an alternative approach. So what you can do is, instead of adding more vasopressors, you can get rid of endogenous vasodilators like nitric oxide and hydrogen sulfide. We should step back a little bit and talk about the role that those have. So those are present in all of us normally, but in some disease states, like in sepsis, endotoxins can trigger a lot of NO to be released. High NO causes the SVR to plummet, and we call that vasoplegia. There are several conditions like this. So I mentioned sepsis. Another is liver disease, where the problem is that your liver, whose job is to break down NO, isn't able to do so. So you get higher NO levels. And then a third situation that we see sometimes is after cardiac bypass surgery. So here, the person's blood has been sitting in contact with artificial membranes, in many cases just kind of sitting there during the bypass phase. And that contact with artificial membranes for a prolonged period can get those neutrophils really upset. And the neutrophils release a lot of nitric oxide. So that can also cause a high NO state, which is vasoplegia.
Nick, so I have to imagine, in keeping with some other comments you've made, you've got an automotive analogy for this one?
Oh, yes. So as an analogy, I like to tell people to imagine a bad driver, somebody who drives with one foot on the gas and one foot on the brake. The speed of the car, the SVR, reflects how much pressure is being applied to both pedals. So with this bad driver, when they want to go faster, they push on the gas. And when they want to go slower, they push on the brake, right? Pushing on the gas is like adding vasoconstrictors that raises SVR or speed. And pressing on the brake, adding vasodilators, it decreases SVR. Now, normally, we think about the problem of having low speed, low SVR, as being a result of not pressing hard enough on the gas. But remember, in this case, what you can do is you can actually just take their foot off the brake. And the way we do this is by scavenging those vasodilators, removing them from circulation. So the same amount of pressure on the gas pedal will make the car go faster.
So, Nick, I think that's a cool analogy, but what are the specific agents that can help us take our foot off the brake and get rid of those excess vasodilators?
So two options, methylene blue and hydroxycobalamin, or the precursor of vitamin B12. Both of these drugs are FDA approved, but as antidotes for other conditions. So they're both being used off-label here. So let's talk about each in turn. So first off, methylene blue. Methylene blue is a really potent scavenger of nitric oxide. It's approved as an antidote for acquired methemoglobinemia. And there are actually quite a few RCTs and one meta-analysis suggesting that if you give methylene blue, the vasopressor dose is reduced and mortality is reduced in people with distributive shock. It has the interesting side effect that it turns your urine this like really bright green color. Hydroxycobalamin, on the other hand, it scavenges nitric oxide and hydrogen sulfide. It's approved as an antidote for cyanide poisoning. That's why we have it in most hospitals. And even though it works pretty well, the level of evidence is a little bit poorer. It definitely raises BP in several trials and lowers pressor requirements, but there just haven't been enough clinical trials to see if there's a survival advantage here. I don't necessarily think one of these drugs is better than the other. I just think there's a little bit more evidence for methylene blue. I should also add that hydroxycobalamin has the lovely side effect of turning your urine a really dark burgundy red. And we'll probably talk about why that's important in a second.
Great. Yeah. So it can prompt some unnecessary hematuria workups, which is always fun. So,
Indeed.
Yeah. So, Nick, how do we choose then between these two drugs? They seem like they both have their merits.
Yeah. So I think first question is, which one do you have? Not every hospital stocks both of these. So perfection is the enemy of good. If you have one, that's probably the one to use if the other one isn't available. If you do have both, the way I decide between them is based on side effects. So there's a couple important side effects of methylene blue to be aware of. Number one, it can cause hemolysis in people with G6PD. G6PD is very common in people from Africa and Mediterranean regions. And the issue here is that if you give methylene blue, they'll get hemolysis. So you don't want to do that. If somebody has a history of G6PD or you suspect it, don't do methylene blue. The other big issue is it can cause serotonin syndrome. So people who come into the hospital and they were taking medicines like SSRIs or MAOIs, you want to avoid methylene blue there as well. Rarely it can cause allergic reactions. Usually it's kind of a less than 1% complication. But I avoid it in people who have G6PD or who are on meds that could cause serotonin syndrome. Hydroxycobalamin, on the other hand, is actually pretty benign. It's not likely to cause allergic reactions because it's basically just a vitamin. But remember, it causes your urine to turn that really blood red color. Well, that actually does cause problems. For people who are on CRRT, there's a little sensor on the machine that looks at the dialysate to see if there's blood leaking into it. And the idea is that this is a safety feature. It stops the machine if blood is leaking out, as you'd want, right? You wouldn't want to lose all your blood out of a hole in the dialysis membrane. But for people who get hydroxycobalamin, it makes the dialysate turn really dark red. And so the sensor on the machine flips out. And so this can be, depending on the machines that you have, this can actually make it very difficult or impossible to deliver hemodialysis. So this is just a concern, depending on the exact equipment where you work. This might interrupt HD or CRRT. There's case reports of this. So it's just one thing to consider in somebody who's got severe acidosis or is going to need dialysis for another reason. Make sure that you can give this drug and you're not going to make their renal replacement therapy harder. Just to summarize all of this, because I know there's a lot, we're going to have an infographic on the website that summarizes kind of the pros and cons of each drug and what the side effects are for each. So check out criticalcaretime.com.
Perfect. That's a great review, I think, of those two agents, Nick. And so, having discussed that, let's go ahead and fast forward 3 days. We'll say that Ms. G has turned the corner after drainage of the perinephric abscess that she had. She was briefly on those 3 pressors. She got a single dose of hydroxycobalamin. But once source control was obtained, she improved quite quickly. She's now awake. She's alert. She was extubated a few nights ago, and her oliguria has even resolved. That all being said, she does remain on a low dose of vasopressors, so she's on 5 mics per minute of norepinephrine and 0.03 units per minute of vasopressin, and this is keeping her in the intensive care unit. Her RN is concerned about getting the patient out of bed because her blood pressure drops whenever she sits up, and then she needs to have a bump in her vasopressor dose. And furthermore, we know that despite our best efforts, physical therapy is incredibly important, and sometimes in the ICU, people don't get as much physical therapy as they might in other parts of the hospital. So we obviously have a lot of reasons we want to try to move Ms. G out of the ICU. So with a patient like this who's kind of stuck on pressors, Nick, what can we do?
So first of all, this is a common situation. It's easy to think of this as benign. Somebody just needs a whiff of norepi. But we have to remember that for every day that Ms. Gonzalez stays in bed, she's over 60, so it will require roughly a week of rehab to recover lost strength. If we can liberate her from vasopressors hours sooner, it potentially means that she will get back to her baseline days sooner. And every hour sooner that we can get that central line out or reduce her iatrogenic exposure, we reduce the risk of iatrogenesis and nosocomial complications. I like to think about that scene in Interstellar when they go down to the water planet and it's really close to the black hole, so they have like crazy time dilation where 1 hour on the water planet is like equivalent to a year on Earth or decade on Earth. It's kind of like that for elderly patients in the ICU. Time matters. Hours matter. Days matter a lot. And anything that we can do to get her off pressors sooner will potentially get her out of the hospital sooner, get her mobilized sooner, and will improve her likelihood of returning to a normal quality of life.
With that being said, Nick, what can we do to actually help her liberate from vasopressors a little bit faster?
So there's a couple of things. The first thing I like to do is move the goalposts. Maybe we can tolerate a lower blood pressure. Second, let's make sure that we wean the pressors in the correct order. Third, let's look for and make sure we're treating underlying causes. And then finally, fourth, I like to think about adding midodrine as kind of a cheat. So let's go through those sequentially. The first one, let's move the goalposts. So in part 1, we talked a lot about blood pressure goals. So we said that in people with septic shock, a MAP of 60 to 65 is our goal. That's people in septic shock. This is somebody whose septic shock physiology is resolved or is resolving. If she's sitting there mentating, urinating, eating a sandwich. She looks good. She might not need a MAP of 65 anymore. So potentially we can drop our goal a little lower, especially if that means that we can get her off the pressors and then get her out of bed. Not true if she's symptomatic. If she like sits up and she feels really lightheaded and they have to trim her pressors, that's a different situation. But there's definitely a subset of people whose blood pressure is low in bed, and that's just their normal situation if somebody's been lying in bed for 5 days. So we don't have to treat every number, especially if she's giving us indications that her perfusion is good and her organs are working.
That's awesome. I love the idea of moving the goalposts, Nick. We talked second about how maybe we can approach the weaning of vasopressors in a way that helps our patient out, and I think that's a good one to really flesh out a bit. So let's take our patient, Miss Gonzalez, who's on vasopressin and norepinephrine, and the reality is we can wean either of those agents first. And so, is there anything that can guide us in regards to which one comes off first? There are several studies and at least one meta-analysis that actually suggests if we wean vasopressin first, the patient will be more persistently hypotensive versus weaning norepinephrine first. In other words, the duration of hypotension will be longer in patients for whom vasopressin is the first agent weaned versus norepinephrine. This just kind of makes sense. So if we recall that many people with septic shock are relatively vasopressin deficient, it kind of makes sense that keeping that vasopressin on a little bit longer and then essentially just turning it off works in their favor. And so really the key takeaway here is definitely consider weaning the norepinephrine first, and then you can pretty much just turn the vasopressin off. There are cases, I'll say, that I've actually titrated vasopressin down from 0.04 to 0.03 to 0.02, and that's really the exception, not the rule, but that's certainly an option as well.
Yeah, I think that's a great point. Key takeaway: wean the norepi first, then the vasopressin. You may get some pushback from your hospital about this because a bag of vasopressin is more expensive than a bag of norepinephrine. But for somebody where it's a matter of a few hours difference, it probably doesn't even mean changing the bag, right? The bag is going to be up for like a whole day, so you can push back on them and say, "Look, this is medically better. There's evidence to support this practice."
That's awesome. I think it's important to have those tools in the toolbox if you need them. So, let's move on a little bit and perhaps consider why someone is persistently hypotensive. We've touched on this a few times now. The idea of whenever there's a new issue that crops up, it's really important to get to the bedside and assess that patient and think what could be going on. So, just like with our sort of ramping up of care as we're trying to wean things, we should really approach that the same way. So again, let's consider why someone's persistently hypotensive, and occasionally critical illness and the things we do will unmask things like adrenal insufficiency or hypothyroidism. And sometimes folks will have vitamin deficiencies, and those vitamin deficiencies can contribute to persistent vasopressor requirements. So all of that is fodder for action, and those are things we should consider.
Absolutely. And, this is an opportunity for iatrogenesis, right? So somebody came in and they were too sick to take their levothyroxine orally. So it got stopped and then nobody bothered to restart it. And now 5 days later, somebody is hypotensive and a little bit cold, a little bradycardic, right? You basically made them hypothyroid because you didn't continue their thyroid replacement. So watch out for that as well. You mentioned vitamin deficiencies. There's definitely a future rant there. We can talk about potential role of vitamin C and thiamine. There might be some patients who respond to that, though. I think treating sepsis with vitamin C is quack medicine. We should probably talk about that more in the future. Maybe instead we should talk about midodrine.
I love it. Yeah, let's talk about midodrine. So, midodrine is a pretty cool agent. It's a cheap generic pill. It's orally bioavailable, and it's a vasoconstrictor. It's predominantly got alpha effects. So it's a medication you can take orally that functionally is a PO pressor. And so unfortunately, like many things in critical care, the evidence is a bit mixed. So we do have some observational trials that are encouraging and suggest that we may be able to reduce duration of vasopressors by somewhere in the neighborhood of a workday, 8 hours or so. But then we've got some more recent evidence that's a bit discouraging, like the Midas RCT, which wasn't a positive study. And then there is an ongoing RCT called Liberate.
Another great trial name, by the way.
Absolutely. Yeah. It's a great trial. Vast, Liberate, Recovery for COVID. I mean, these are all so inspiring and so exciting.
We should actually do a list at some point of not just the most important clinical trials, but the best clinical trial names. And they're not always the same.
I think that would be a great idea. I totally agree with you.
One point that we should add about midodrine is it's going to take a while to work. Remember from pharmacology, this concept of 5 half-lives, that's how long it takes for a drug to either wash out of your system or to reach steady state. Well, if you're taking midodrine, which has a half-life of the active drug of about 4 hours, that means, 5 half-lives is 20 hours. So if you start it, don't expect the person's blood pressure to be, fixed right away. It's going to take a couple of doses. And so if you want to see the benefit, you really do need to start it early. Don't wait until the person has been stuck on pressors for a few days and then start it at a low dose. If you're going to use it proactively. And use it early and use it at a reasonably high dose too. In some cases, I'll even start midodrine on the day of admission. If somebody comes in and they have kind of smoldering septic shock, they're on a low dose of pressors, I'll start midodrine right away with the hope that I'll get them off pressors maybe 8 or 12 hours sooner, maybe on hospital day 2.
Nick, we've discussed that the data for midodrine isn't great. Are there any alternatives?
Not really. So theoretically, PO phenylephrine or pseudoephedrine could work, but there really isn't any data for this. So I would say don't do that. Sometimes people will try giving fluid. They'll just assume that, maybe this person needs a bolus to get off pressors. Maybe if you've been diuresing them really hard and you have to give a little fluid back. But I just, most people who are at the end, the later in critical illness are volume overloaded, not hypovolemic. And so chances are fluid is going to do more harm than good in most of these people. So be cautious about just reflexively giving fluid. And then finally, right, there's sort of this weird sort of self-fulfilling prophecy, right, which is that people stay in bed because they're on pressors. Sometimes getting people out of bed is a great strategy to get them off pressors. So don't hesitate to put somebody up in a chair if they're on pressors. If their blood pressure falls, obviously, lie them back down. But sometimes mobilizing people is a great way to wean from pressors as well. One final point to make about midodrine. Be sure to stop it. So there was a study recently that found that 50% of people who were put on midodrine in the hospital go home on midodrine, in many cases with their home antihypertensives also restarted. That is just polypharmacy at its worst. Don't do that.
Yeah, it's an incredibly, incredibly important point, Nick. And it kind of reminds me of something we sort of touched on a little bit when we spoke with Dr. Ely about delirium and how sometimes we'll start those atypical antipsychotic agents, even though the data is not strong, but we'll use them acutely in the ICU. And all of a sudden, despite the black box warning for continued use, the patient gets discharged on something like quetiapine. And it's certainly worrisome. So definitely, this is a great reminder to put stop dates on medications like antibiotics, antipsychotic agents used as I described, and things like midodrine. And clearly make sure you're documenting and communicating handoffs when you're passing this patient off to the internal medicine service as to why the patient's on a particular drug and when that should be stopped. So it's important. It's so critically important to our patients that we do everything we can to avoid what is sort of an embarrassing mistake.
Yeah, great point. Great point, Cyrus.
Thanks. So we've been on the line here for a while. I think we probably need to save Ms. Gonzalez finally after the ordeal that she's had. So we'll go ahead and we'll start her on 15 milligrams of midodrine 3 times a day, which facilitates weaning off norepinephrine and then vasopressin. She is well enough to participate in physical therapy. She leaves the ICU on hospital day 5, does a few days of physical therapy on the ward, and then discharges the hospital on day 7. 2 months later, you call her to check in and you learn that she's doing great. She's back to her baseline, no issues, and best of all, she is not on midodrine.
Thank God. Okay, well, that is a happy ending.
Indeed, a challenging case with several great twists and turns, but ultimately, Ms. G did great. And
each of those twists was an opportunity to talk about some cool aspect of physiology or pressors. It's almost like we planned this.
It really is like we planned it, Nick. And in fact, we did, oddly enough. So With that being said, we've covered a ton of high yield content here, and we really hope you guys enjoy it. I think it's important to take a moment here to summarize some of the highest of the highlights. And I'll start by saying, refractory shock is not uncommon in the intensive care unit. And in part one of this two-part series, or two-part episode, I should say, we talked about the basics of vasopressors and who we should start them on. But it's really important that you have a plan for when the basics aren't enough. And it's what I mean by that is it's important to have the tools to manage refractory shock. Whether those tools are vasopressors or steroids or salvage therapies, it's just really important that you're comfortable with all those modalities.
Absolutely. And I think the other key take-home point is always be reevaluating. Every time you up the ante, you need to add another pressor, you should always go back to the bedside. You should always ask yourself, could I be missing something? Remember that, good medicine involves examining and re-examining, looking for the thing you might have missed before. And our good old buddy, the ultrasound, is a great aid in doing that. Finally, don't forget about your exit strategy. Whether that means starting diuresis to decongest somebody, or starting midodrine to help wean them from pressors, we need to be thinking proactively about how we're going to liberate people from the ICU. We spend way too much time thinking about how to escalate therapies and not nearly enough time thinking about how to de-escalate them.
Great points, Nick. And on that note, thank you all for taking the time to listen to this episode. I know it was a lot of content, but we hope you enjoyed it, and we hope you're enjoying our show. If that's the case, be sure to subscribe, give us a like, and please, please, please leave us a 5-star rating on your favorite podcast app. This helps us tremendously expand our audience, and it means the world to us.
We do read your comments. And be sure to check out our website, www.criticalcaretime.com, where you can find the podcast, the videos, infographics, show notes, kind of going over everything that we talk about in the show in written form. Also, we'd love to hear from you. Tweet or X at us at CritCareTime, or to each of us individually at Nick M. Mark or at Askins Razor. You can follow us on Instagram and Threads. We're on all the places. And also be sure to check out our YouTube channel.
We are fortunate in that this episode and all episodes in Season 1 of Critical Care Time is sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
And before we go, we've thanked our audience members. Thank you so much. We also want to thank the incredible members of our team who make this show possible. We couldn't do it without everybody. We'd like to thank our production team over at Podpaste. And last but certainly not least, Kurt Belknap for the awesome theme music you're about to hear. Lastly, some just a reminder, the podcast and all the related media, including the animations, the graphics, the videos, are property of Critical Care Time. You're welcome to share near and far. We just ask that you cite the source.
And of course, the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. And finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, thanks again for listening. I am, once again, Dr. Cyrus Askin.
And I'm Dr. Nick Mark. So long. See you next time.